Thank you all for coming. Today we're going to be talking about ending the pain gap. And this came out of some research that actually we had released back in November. And I wanted to share a little bit of that with you guys today. And then we're going to be having a discussion where we talk a little bit more about what this data, how these trends apply in broader areas of women's health, as well as other indications that might, disproportionately impact women or just impact women, period, and have some discussion about maybe what we can all do to advocate to kind of fix some of these systemic issues we kind of continue to see over and over again. So if we go to the next slide. So where did this come from? Overall, you've probably seen some of these articles. There's been a lot in the news over the past several years and even more attention in recent years on kind of what's going on with women when they have pain in particular and within women's health indications specifically as well. And doctors potentially dismissing some of these patients' pain and what they report, or not recognizing it, taking too long to recognize it, and maybe treating it in ways that aren't actually getting to the problem, which can cause inadequate treatment, let's say. And so we wanted to look at this a little bit further. And what we did was we had access to some data from Komodo's PRISM data that we used in-house, and we wanted to look at a few different conditions that impact women. Specifically, we were looking at endometriosis, where we know that there's a long delay between onset of symptoms and diagnosis today. We looked at PCOS, where again, we see from other data that women see an average of 3 doctors before they actually get a diagnosis for that as well. Fibromyalgia, which is another one that has a lot of stigma, things attached to it. Women often have to see multiple physicians and wait over 2 years to get a formal diagnosis. And then we also looked at issues like IBS and migraine, which of course also impact men, but kind of tend to disproportionately impact women, and they're more likely to have more severe symptoms. So we chose these 5 groups, and what we wanted to look at is just take another lens at this and see if we look at their claims data, what's coming through insurance, what's going on? Can we look at their mental health comorbidities, what's going on with their overall wellness that way? Look at other medications they're using, medications both indicated and not indicated for the conditions that they have. And overall look at their healthcare utilization by using like number of visits as a proxy. So we looked at that for women who had each of these 5 conditions, and then controls of women who did not have these conditions, but were also weighted to be the same age, so that we had kind of a fair comparison cohort. So if there's a lot more info on this. I can provide more info on how we did this, but essentially we weighted them to match and looked at each of these different things through looking back at the kind of last full year of data that we had, which was 2022. So what did we find? Overall, we found that women with any of these diagnoses are much more likely, sometimes 2 to 3 times, more likely to also have anxiety diagnoses in the last year. So a big increase, and particularly with both IBS and fibromyalgia, but we see it consistently across the conditions. And all of these numbers, by the way, are statistically significant at the samples of which we have. And we also looked not just at anxiety, but if we go to the next slide, we also looked at depressive disorder. Same trend, particularly fibromyalgia, that is kind of often part of the diagnosis process, so a little less surprising there. But the fact that we see it again consistently across all of these issues is indicating to us there's sort of a broader impact. Now, these are all correlations. I can't say causation. I can't say one causes the other. We can't say that with claims data. But we can certainly see a pattern emerging and start to see that there's something's going on with the way that we're treating women's pain by looking also at kind of their mental health. So what are they being treated with? We looked at some indicated medications. I will say we're not looking at, I know some of these conditions are also treated with surgery that was treated separately from this, so that's not brought in here for the last year. We're looking really at pharmaceuticals. So what we have looked at here is we can see that, again, when we look at our cohort that has endometriosis versus our control, yes, they're more likely to have indicated medications, but it's not even 60%. It's a big percentage completely not getting that treatment. And they're more likely to be just getting, or equally likely in many of these cases, to be getting opioid pain medication or non-opioid pain medication, right? Versus an indicated treatment. And then we see big gaps when we go down all of the ways as well, in terms of the number of these women that are being treated with anti-anxiety and antidepressants. As high as 77% of the fibromyalgia group, but really high also in the IBS and migraine group. So kind of we're treating pain by treating depression and anxiety instead of potentially getting to the root and treating some of the with indicated medications. So we go to the next. So this is just calling out that difference too. And I know we all talk a lot, we look a lot at the opioid pain epidemic. And, just again, we see it can be concerning. Some of these women are really utilizing a lot of opioid pain medication in 2022. Now this could just be one prescription. So, we don't know what specifically, again, this is claims. We don't always know what that was prescribed for. But again, you can see the pattern and the fact that there's a lot more of that being prescribed in some conditions than actually indicated treatments. And then they're overall just taking more medication. So what we found overall is when we looked at this, at the bottom, they were more likely to be taking 2.5 to 8 in the case of fibromyalgia, unique prescriptions in the year 2022. So these aren't just the indicated medications. That's not enough to account for the difference, right? So there's just a lot of additional things they're being treated with. It's compounding. We're leaving these women needing a lot more solutions to get to the help that they need. We go finally, the next one, we also then looked at how they're utilizing the system. So not only are they on more medications, but they're seeing more doctors. So throughout the year, the average number of visits for most of our controls was, about 15 visits across like any specialty. If you look across any of the groups of controls, and that's all of their outpatient visits, any doctors that they saw and had a claim for in the year. You see that increased by about 5 with endometriosis patients, and that's non-indication specific visits. That's not a visit that was marked as for their endometriosis. IBS, it's about almost 7. PCOS is one of the lower ones, but still 2.5 to 3. Fibromyalgia, almost 9, and migraine, we're over 4, 4.5. So again, they're trying to seek help. We're seeing them see more doctors. They're utilizing the system more. And yet, likely, this data indicates to us there's some dissatisfaction. If you need to keep getting more medications, more doctor's visits, the treatments you're getting aren't meeting your needs. So we had some high-level conclusions and probably just reiterating what I've already discussed here. But the women are diagnosed with endometriosis, PCOS, fibromyalgia, IBS, and migraine. They have significantly higher rates of depression and anxiety. They're more likely to be getting those antidepressant, anti-anxiety medications than controls. And they're also not receiving indicated treatments for their conditions, but are still more likely to be, in some cases, they're still more likely to receive more prescriptions overall in order to treat the issues that they're having. And the women are receiving significantly more opioids, which is always a bit alarming to us in terms of how they're treating these pain issues. And women with these conditions, again, have significantly higher health service utilization, 4 to 8 more outpatient visits per year. So I wanted to share some of that today before we jump into our panel discussion, because it was sort of what, for me, inspired the topic that we're talking about today. And I'm happy to answer any questions about it after. But before we do that, I kind of wanted to introduce our panelists, or actually let them introduce themselves a little bit here. And I realized that in doing so, I was remiss that I introduced myself at the start. I jumped right in. So I'm Caitlin Austin. I'm a VP here at Charles River Associates. I've been here about 8 years. I work in strategy and commercial insights as well as medical affairs insights across a range of therapeutic areas, but women's health being a particular passion and also very timely with my current condition. So I'm sure that'll come up a bit in our discussion today. But I'm going to go ahead and pass it first to Jessica, if you want to share a little bit about yourself before we dive into the discussion.
Sure, I'm Jessica Malberg. I'm a senior medical science liaison at Sage Therapeutics. And I've been at that role for about 2 years in medical affairs at multiple companies for about 10 years. But I started off in a preclinical role, then also went into clinical development. And I currently work on postpartum depression, which has a lot of overlap to the unmet needs and unmet gaps. So even though this was about pain, this is so overlapping on what our unmet needs are.
Hi, everyone. My name is Michelle Cole. I work at Sumitomo Pharma. I'm a PharmD by training, and I have a master's in health economics, and I've spent the last, say, 10 years or so doing health outcomes research and also presenting to payers. Prior to that, I was an MSL, which I really loved. That was a lot of fun. I'm really excited to be here today because I've been working some of this endometriosis data is really resonates. That's the area I work in now. And even maybe about 10 or 15 years ago, I worked in pain management. So we kind of saw really nothing changes. It's very sad. It's just like the same kinds of things where women, they're not believed or, they're hysterical or, when you think even the root Greek word for hysteria is associated with hysterectomy, so it's like that whole, remove the uterus and it's kind of like my focus now with my job, but it's really just shocking how little has changed in, thousands of years, really. So it's sad, but hopefully here tonight, shed more light. We'll talk about it. We'll talk about tomorrow.
Yeah, this is exciting. My name is Dylan Johnson and I work at Takeda Pharmaceuticals. I focus mostly in GI and I'm like Caitlin, I'm in market insights. I've been doing market research for about 20 years in healthcare in all different categories. And yeah, I see this primarily as a promotional and educational issue, right? For physicians and for women and people who know women, who have them in their families. So yeah, it's very interesting.
Thank you all. So I talked a lot. I went through a lot of information that we've captured here at CRA, but I really am interested from each of you in terms of how you see these trends that we've kind of observed here in this one claim study kind of playing out in your own experiences. And Michelle, I'm going to actually start with you just because I know you're in the endometriosis and uterine fibroid space, so maybe the closest to what we looked at here. Is this consistent with what you've seen? What else are you seeing in your work and your data in addition?
Yeah, so we did some work that's somewhat similar. We looked at patients and we did a patient journey study, which is basically you look at a claims data set of medical claims de-identified, and you look at patients who, in this study, they had endometriosis with two ICD codes of that. So they had it twice in their chart. And then you see what happens to them. And like 50% it's surgery, and that's it's like right away after the diagnosis. So they're not offered like medical management, even though it exists. There's also a relatively high use of pain medications, which may be in part due to postoperative use, but there's just higher use in general. And then guess what the second most common reported treatment was no treatment. So 50 or so % got hysterectomy, got surgical intervention, of which hysterectomy was about 20%. And then the next most common was, nothing. They just received nothing.
For the counter, maybe.
Yeah,
medication.
maybe over the counter, which we can't see in a data set. And then even second treatment was also against surgery. So second line treatment after getting some medical management, and then no treatment. So it just makes you think like, and then we've done, in addition to that work, to supplement that, we also looked at social media. And it was actually my partners at Pfizer that did this, but they basically looked at influencers, social media hits, And you just see a ton of frustration, like patients like, nothing helps. No, my doctor doesn't listen to me. I'm not getting any treatment. They say, well, maybe it'll go away. And then you see 2 years of no treatment. And, their pain can be as bad as labor pain, but it's every day, and dealing with that and then working and doing everything else. So it's really just shocking and sad, but hopefully, again, we'll continue the discussion.
So Dylan, I'm going to pass it to you next because I know you work a little bit more broadly, obviously, and GI and some of the other areas you've worked in the past. But I know you also have some other data that you've seen recently from WPP and other areas that you wanted to share also that shed some additional light.
Sure. So similarly, I speak in surveys, right? So I went looking for some big population surveys of women because this isn't something I get a chance to think about specifically in my work a lot. And in 2022, for instance, WPP Health, which is like a big conglomerate of ad agencies and promotional groups, they worked with a nonprofit called See Her to produce a report called Health on Her Terms, where they surveyed 1,500 American women and non-binary people on their attitudes really around all kinds of, things in the media as well as healthcare and how they viewed themselves. And these were weighted across all different, differences that women have to try to get the best representation. But what popped out at me is 40% of women agreed that they have felt not listened to by doctors or caregivers. 40%. And that really fits with what you see here. And you talk about going to many, many doctors and getting different kinds of medication. And this is even higher among women who had reported that they are older, right? Like older than 40 or are either overweight or underweight by their own report in the screening information. And there was a quote there that I found really surprising. When you think about weight, for instance, there, and I want to get to like intersectionality of just being a woman is pretty hard, but it gets more complicated very quickly, right? This one woman said, nearly every doctor has said that every single concern, including depression, can be cured by losing weight.
Oh my God.
Despite the fact that my blood work and other exams attest to the fact that I'm healthy besides being overweight. So this is a pretty educated person who's getting this feedback.
Yeah. So I think it comes back to that not being listened to, and then the downstream that's like, how are we treating women holistically, right? Like thinking about what this pain is indicative of maybe other conditions that they're suffering from. And so I'm interested, Jessica, you working more on the psychiatric side and in postpartum. How do these kind of trends resonate with you and what you see in your day-to-day work?
Well, a lot of those slides resonate highly. There's a huge comorbidity, and again, we don't know which comes first, of pain disorders, especially IBS, which was interesting, and depression. It's both. You get a greater amount of depression, and it's also a risk factor. It is a risk factor for PPD, definitely. And what I also found really resonated that people were not being given the gold standard, which from our point of view, at least in PPD, you get screened, the best of all worlds, screened, diagnosed, and treated. And I could go into a whole discussion about all the data gaps. But from those slides, even if they're being screened and diagnosed, they're not even being treated with the adequate drugs. So there's so many data gaps that we could address with advocacy and really education. And that's one of the things we're looking at. So that's what spoke most to me from those slides.
So thanks. And I know we've talked a little bit about this, I think all of us in the past when we were chatting about this panel prior, but that the cost is not just to the women too. There's cost to the healthcare system, there's cost to the economy at large when it comes to insufficiently treating women's pain or holistically treating their pain, mental health, other downstream issues that kind of seem to correlate together. And so I'm interested from you guys in your experiences. Is there anything you can share on kind of what you've seen as the costs? Dylan, you have a stat the other day that was shocking.
You know what? I don't have a good stat on the actual cost. I have some some more discrimination kind of things, but I think we were talking about this and I just had this personal memory. of talking to my grandmother and telling her that this 40-year-old woman I knew who was the wife of my boss's husband, the wife of my husband's boss. We don't have a name for that relationship. And she died suddenly of an unknown heart condition and had 4 children at home. And my grandmother said, nobody takes out life insurance on stay-at-home moms, but how would you pay for all of the things that that woman does, right? And all of the services that you're losing in her managing that home and her husband working in a different city, right? So that just made me think in general about how hard that is, and that's probably a survey I didn't pull for you.
That's fine. Michelle, I'll kick it to you next, because I know we recently looked at some of this.
Yeah, we looked at some costs.
information.
Yeah, we, through our research, and we worked with Caitlin on, specifically to endometriosis, in general, they are more costly to a healthcare system, and we do that by looking at hospitalizations, outpatients visit, and medication. And it's not that surprising that people with an illness cost more than the cohort that doesn't have illness, but it was 3 times, that's pretty significant, and a lot of those costs, again, were surgical costs, which, when there's medical management, the surgery is not always first choice, and I've had a lot of people who've worked in this area say to me, well, if it was a man, you think they'd ask them to cut off their testes, instead you're asking women to remove their uterus or ovaries. So it's, there may be some undercurrents of, cultural bias, unconscious bias that's going on when women are it's in the healthcare system, and then that can really, make it more costly for overall services. So you'd have to kind of look more closely at, at what point is the tipping point where, if you just looked at costs alone and you took away the patient needs or preferences or whatever, you'd have to determine like, where is the cost coming from? Is it more hospitalizations related to surgical procedures? Is it more of the medical management, and come to a decision point there? But we're not quite there in the US. Like a lot of things are, you want to, what does the patient want? What does the doc say? What do guidelines say? So, there's a lot of kind of things to consider. Did that kind of I kind of went off, I think.
No,
Sorry.
that's great. And Jessica, I know we've talked, it's kind of hard again to put a number to it, and I'm not gonna ask you to.
We actually do have a
Oh,
number.
you have a
We
number.
do.
Oh, I'll let you throw it out then.
So we have numbers, and then we also have some personal costs, and I qualify if I was giving a presentation, there's a slide, and I hate giving it because it puts all the stress on, this is what happens when you have undiagnosed PPD. So at every milestone looked at, and we do a lot of work with the Yale Child Study Center, looking at gaze and interaction. All the developmental milestones of babies, including even up to, and they don't do this at Yale, but they have done some studies that at 18 years old, children of moms who are postpartum depression had a greater amount of reported depression. Whether that's from being exposed to a mom who had chronic depression throughout her life, and we don't know what the correlation, and we know there's an epigenetic and genetic component of all of these, but nonetheless, you see a deficit in all of those developmental points. So, and also there's been studies now looking at the partners. So the partners report a higher incidence of depression and less happiness. Well, obviously we need less happiness with both your partner and just general depression. And the cost for the first 5 years of life is $14 billion.
Wow.
That's a lot
was
for
not
under treating women. And I guess my next question was going to be going to you guys too about kind of personal experiences, and building off of that one. I know we talked about one of my personal experiences now that we've got this little boy growing, but I've just been waiting for someone to screen me for for prenatal or depression, and to educate me on it.
And
The
I
most
assume
I've
you
got-
have a good, you have good
Yeah,
insurance.
I have great
This is-
insurance. I have a
this
great,
is-
that the most that I will say I've received in this healthcare system so far is a folder full of like 20 different pamphlets and pieces of information that included, yes, one on postpartum depression with some very high level information in there and how to kind of recognize signs and symptoms, alongside things like cord banking and things on, local groups that you can get involved in, and women's groups and other things. Like there's a whole slew of things, as well as stuff on, the importance of breastfeeding only and breast is, you know, like all these things that like kind of feel like they're like yelling at the women, right? And I'm like, you could so easily just never look at that folder. And if that's what our doctors consider educating you on how to recognize these signs and symptoms, it's no surprise that to me that, and I'm someone who's, I'm waiting for someone to do it. I'm sitting there like,
Oh, yeah, and Caitlin,
Are you
you
gonna
said
screen
something
me?
like they asked you, are you feeling
oh,
sad?
am I feeling sad today? That was, and I kind of wanted to pause and just be like, was that you screening me? Or
Yeah.
like prenatal, that count? Cause it shouldn't. Let's be real. And so, you know, I think this is a continuous area where it just all the more made me like want to self-advocate more and get out there and be like, you guys need to do better by everybody, not just me. But yeah, I'm curious about you all, and if you're comfortable, of sharing any of your like personal experiences where you've experienced maybe that feeling of not being listened to or feeling like you need to self-advocate for yourself. Even as women who do work in this industry and know what we should expect, it can still kind of happen.
I've done I've been waiting for my cardiologist and I fill out a PHQ-9, even and I'm just like, "Ugh, I even do it?" Like, it just, I understand why they need to do it, but really it becomes just rote. And that being said, for prenatal visits, it might be a little different because it's actually, PPD is more common than gestational diabetes, but they do a blood draw all the time. And no one complains about that. And so if you could move that into having a normalizing of mental health in general. And then also for my like everyone I see at the West Mid Medical Group, it's the point where I'm not even looking. And I want to say, if I actually checked one of those, what would happen? Because it seems that they're not looking at it either.
Procedure.
Yeah, I was just realizing just last week when I was thinking about this and you're talking about migraine, I get occasional migraines. I don't have severe chronic migraine, but I have a great relationship with my PCP. But I've been telling her for a couple of years, you know, had bad migraines years ago, it went away for a while. Our bodies are weird. They came back. And I said, I need, 100 milligrams of sumatriptan, please. That works. And she's like, that's a lot. Is that what you were taking? I'll give you 50. And I said, okay, whatever. And I tried those for a couple years. And finally I asked a family friend who was a physician, he's like, don't you just take 2 of them? And I'm like, can you really do that? I'm such a rule follower. And so this last time I went in and she's like, you've been using a lot of the sumatriptan, you need more. I said, I need the hundreds. You told me to go to a neurologist. I'm not going to a neurologist. I don't have time and I don't have severe migraine. And she's like, I said, I take 2 of them. And she finally wrote it for 100.
You had to ask a few times though.
But yeah, it's
didn't
been
you?
a couple of years. It's been like 4 years.
Yeah.
Well, I mean, this story came to mind because, you're with child and, I remember when I was in labor, it's a little while ago with my, daughter, I was in labor and I was like, can I have some pain medication? I worked in pain medic. That was my job. That was what I did. I was like, can I please have a PCA, and they're like, well, I think we are exhibiting some drug-seeking behavior. I'm like, I'm in labor. Like, I don't know what that means. And drug-seeking behavior occurs over a period of time. It's not like a one-day kind of thing. And I'm I'm legit, and it was just, yeah, they're like, you're hitting the PCA too much, but I said, but it locks out, you kind of like speaking and you're like, am I on another planet? I mean, like, I'm in labor and I just found that so amazing. I hope it's different for you now. My daughter's 16,
I
so.
think now they actually might push the other way more aggressively, but yeah,
That was shocking to me and
but we
upsetting.
still see things like, I think, we showed a part of it on the slides earlier, but I don't know if anyone saw the Washington Post article from a few weeks ago, maybe a month or so ago now, from the IUD insertion.
Oh,
And women were
yeah.
taping themselves, getting their IUDs in excruciating pain, and the doctors were telling them that they weren't in pain. And weren't offering them pain medications, weren't offering. So these things still happen there and they question it. And when women take surveys about it, we've seen that like they rate it, women who haven't had a child rated their pain about like a 7 apparently on average for receiving an IUD. And women who have had a child rated it at 5,
Mm.
which to me is really a 7. It just means you have a different point of reference.
Reset.
Right, like, and
Mm.
it just killed me because I'm like, and they're not offered pain medication. They're told to just take an ibuprofen before they come. And you gotta think, would we do this to a man getting a vasectomy? I don't think so. I don't think we would. So I do think we treat women's pain differently or almost as expected, something that we're expected to put up with. And I'm not sure we should accept that anymore. And so I wanted to ask you guys as kind of our last question, we are all women that work in this industry in different ways. From your perspective, what do you think is something, again, this is systemic, there's lots of things that probably need to change, but what do you feel like is maybe one thing that we could do or that you think that could be done to kind of just push this forward, try to inch ourselves to advocate a little bit more for women? I'll start with you, Jessica. this time.
Sure. So a lot of the things that you've said of like just power through it, everyone, that could equally be applied to postpartum depression. Women, depending on their cultural bias also, basis, are given all sorts of information from their culture. Their doctor then gives them other information, but it's all downplaying their pain and their depression and pain. And what I would say is sort of, again, normalizing mental health, asking someone and telling people it is normal to have baby blues for 2 weeks. And then if it's not, that is something different because people don't even understand what the baseline is. Okay, a lot of people cry for 2 weeks. It almost always goes away, except in 1 of 8 women who it doesn't. And so letting people know what's normal, what's expected, and then immediately seek help. So
Right.
I guess really education and especially postpartum depression. And it's a shame that it was just one pamphlet because there are a lot of nonprofit societies, Postpartum Support International, that give lots of things and even CBT online, which is very effective. But again, it's not called out and you look at it, you're like, I don't even know what on this pamphlet to even pay attention to.
I've got to say the baby list emails and things that I get have more information sometimes than on mental health and postpartum than a lot of the things I've received from the actual OBGYN office. So something to think about too, how we kind of get more of that information at women's fingertips.
Yeah, no, I think a lot of things you mentioned about, the need for this, the unconscious bias that exists in practitioners and maybe even within ourselves, that we accept this lower level of treatment for pain and other illnesses that you mentioned. So how do you go about changing it? How do you change a systemic bias, right? What do you do? I mean, I don't know, like a government initiative, a health plan initiative, some way to kind of try to make a change over population health. If there's a way to do it, I think other countries do it pretty good, maybe like, I'll pick on you, like England, I think does a good job of, educating and so on and, but maybe we need a more standardized way, not a bunch, I mean, I got all those pamphlets too, and it takes a while to go through them,
Yeah.
and, things get lost in there. Maybe a more sort of strategic way of imparting information. And then also training people to not be biased, to not dismiss depression, depression is related to other comorbidities and, maybe suicide, there's other more tragic consequences from not treatment, so.
Yeah, I always think when I look at the data that we've looked at and some of the data that we showed today as well, and kind of how can we incorporate looking at that data more holistically too, when we're
Mhm.
evaluating new
Yeah.
treatments and things like, yes, it's indicated for endo, we have specific endpoints for that, right? We're gonna look at that, of course, but how do we build in more of those holistic measures too, so that we're really thinking about those downstream effects and how it kind of impacts women and healthcare and their families and all of the things that
Huge.
we contribute, right? In bigger ways, because I think we always see, and I know I don't have a payer colleague here today, but I know we've talked a lot about this also. In that, quality of life data and those kind of things aren't always valued, but if we can really put more value on what
Right.
those items are, maybe we can start to change that.
Mhm.
Yeah, I mean, from a commercial perspective, I see a big opportunity, right? The way we talk to physicians about what you're looking for when you're looking for this condition, what you're screening for, what different ways it could look in different types of people and women from different cultures and backgrounds. And even for women themselves, right? They've said in surveys that they don't see themselves reflected when they see women in advertising, right? In the US, we have all this direct to consumer advertising. There's a lot of money spent, trying to show women with severe cirrhosis that they can wear a short skirt. Is that really the point of that, right? And, do all of us, look like the women in a fashion magazine who are going to be patients? It would be nice to see overweight women in ads that are not for weight loss medications. Underweight women ever but not glorified, right? I'll just throw you a few more stats. So there was a big study done by Harvard School of Public Health back in 2017, but not really affected by the pandemic. We've got before and after is kind of safe. So they did a report with NPR and Robert Wood Johnson Foundation called Discrimination in America, which is actually amazing. It has a separate report on all these different groups, including a report on white people, which I haven't gotten to yet because I'm not really first interested. But there's one on women, right? And they have an agreement statement that I've been personally discriminated against because I'm a woman when I've gone to a doctor or healthcare clinic. And 18% of women have agreed with that. In a cross section of 1,600 women across the US. That is higher than white people, which is about 5% overall, Asian people, and similar to Latinos and Native Americans. We feel about the same amount discriminated against for that characteristic, but less than Black Americans, which were at 32. So when you think about Black women, Latino women, right? Like, where are we putting them? And there was one question that I thought, well, no one will have agreed with this, that I've avoided going to the doctor or seeking health care out of concern that I will be discriminated against because I'm a woman in this case. And for LGBTQ women, 20% of them agreed with that. And so I feel like if our communications to physicians and the healthcare system can try to show more of what real people are like, what they might be saying, what they might be alerting to or hinting at that they don't have the right words for that come from the medical school textbook, then that can only help. I think of the university brochures where you see a group of students sitting around and there's one from every ethnic group and they're all mixed gender. Like, we don't need to do that. But if we can just have more opportunities for more diverse views.
And equally, there was a poster at an annual nursing convention. It was a nursing student at Columbia who looked at really did a deep dive into translations of a lot of the mental health screening tools. And when she really read it out loud to someone whose language is not, it's not English, it was often some confusion on what those words meant. And so really being culturally sensitive to how you get at someone's experience.
Yeah.
So that was really.
Yeah, you can't chatbot these things.
Exactly.
All right, well, I mean, I think we've maybe even identified more things that we need to solve here today. But it's been a great conversation. I'm gonna actually open it up if we have some Q&A.
As someone who's, I found out I had endometriosis when I went to Sloan Kettering and had a hysterectomy.
Oh,
That's when I found out I had endometriosis and I battled with fibroids, but I guess my question is more around, and I appreciate that there's sensitivity around this, with the changing of decisions about women's reproductive choices. What can we do? I lost twins in my second trimester and I wound up having to have a medical abortion, which in some states would have been considered illegal. What can we do as advocates of women to help ensure that we maintain women's care in those type of situations? Like, how are you guys, like, is there anything you guys are doing as companies or as advocates of women, and how can we do that as women?
That's a great question. That's a good question. Yeah, I mean, I think you bring up a great point about advocacy, right? And there is a lot of advocacy online, you know, when you can find influences who are specific around uterine fibroid or endometriosis or women's health in general. And you can read up on that, and see what they say. But sometimes there's biases there too, you know, there's, oh, hormones are bad for you, or surgery is bad for you. You know, you have to kind of, the ones that seem to be, when we looked at this, you know, there's high quality information out there, usually from like a health system, right? Or a physician, you know, may have a blog or whatever they're. So that may be one way to access information and become a very informed consumer of your own health, you know, to then access providers. But I think overall, there's very little research for women in research dollars. So there's just, you know, like we're curing cancer and that's great, but women's health gets, on the big pot of money, women's health doesn't get nearly as much as what it would need. And it's obviously half the population, and endometriosis is common. It's like 10% of women have it. So it's high. Did that get at your question about?
Yeah, gender mutual.
Okay.
Yeah, I think I've followed the Guttmacher Institute. It does a lot of work. I don't know how well connected they are in these directions exactly, but yeah, there's a lot of education to be done about just the health concerns to women. These are women's medical issues.
And what we've been seeing in, at least for postpartum depression, one of the symptoms is feeling that you are not able to care for your baby in extreme circumstances, not hurt your baby. In lower socioeconomic groups, the women are concerned that CPS will be called, and that is a very valid concern. And so if the provider doesn't explain what a designated reporter is versus understanding what their symptoms are, that's another barrier inherent in underdiagnosis, and we're trying to work on that as well.
Yeah, if you add racial discrimination to some of these ideas of the hysterical woman who is acting crazy because she's got a mental condition, it takes me right back to Salem, Massachusetts, right? It's frightening.
And they may be frustrated because they may go to a doctor after doctor after doctor, and, you know, like endometriosis takes 4 to 7 years to get diagnosed, you know, and depression is also has a sort of a long time till appropriately diagnosed. So it's difficult, but I think overall there should be more money for women's health, period.
Yeah.
And women maybe are just too busy to advocate for themselves, or they accept this sort of lower level of attention in terms of research dollars, you know, at NIH level and government levels. So,
I'd say talk more.
Yeah,
I think
like,
all of
'cause
us
women
have
don't talk about their, you
opportunity
know,
to talk more.
like, do you remember before, like, I'm dating myself, but like before the antacids and Pepsi and all that, no one was, oh, I have gas, I'm belchy. Now everybody says oh, I have gas. It's like, it's no big deal to talk about your GI problems, but women still don't talk about their issues, you know, because they're not comfortable.
Do you feel like it's changed since the study came apart that, you know, women in their like periods, it's similar to a heart attack in men? Do you feel like that's changed it at all or no?
What do you
There was a
mean?
study done that the pain of
Oh.
women in their periods
Right.
is equated to a man having a heart attack. Do you feel like that's like woken anything up, or do you?
I don't know if that's well known or well, like, out there enough, you know?
Yeah, I mean, I think there's a lot of things that we've seen different pieces and parts of the
Mhm.
data coming out, and ultimately, I think some of it breaks through and some of it
Yeah.
doesn't. And let's face it, the halls of power or the things, whatever, are still very male dominated. And it's women like this, it's women that we work with. I mean, I certainly think in healthcare, we have a bigger voice as a proportionate of the workforce in healthcare. And my perspective and why we want to have more conversations like this is to drive more conversations like this. It shouldn't happen only in small rooms. It should be happening in
Right.
big halls and other places too. The more we realize our own power, we are more than half the population.
Mhm.
We have more spending power than many of the population. We're becoming more and more of the C-suites and the influencers within our own organizations as well, to not leave those issues behind.
Mm.
And I think,
Yeah.
but
Like destigmatizing it essentially,
destigmatizing
somehow
it,
doing
talking
that by
about
just
it more,
talking about it.
being more visible with these different issues. And I think those things are happening, but yes, you're right. There's been backlash. There's certainly been, we all live in this complex country. But I think there's, the more we raise our voices and have influence in, companies that have a lot of influence also.
Yeah.
Those companies get listened to also. So I think that's the direction I guess I will leave us in without getting too far into any political queries in today's conversation. We could talk about that there. Our networking.
Were there more questions or?
Yeah, I think you have one over here.
Yeah, it was completely kind of switching topics, I
Yeah,
guess,
no.
as we've seen some of the digital health platforms like care management, or I know when I was pregnant, had my son, my company offered like access to Maven. Have you seen that make any kind of dent in some of these issues? Because it's a little bit, you don't have to go to a doctor. It is a little bit, hopefully more accessible, obviously still maybe employer dependent, but just curious if that's come up at all in any of your like research or anything that you observed, just like see if it's made a difference.
We had an active digital therapeutics group looking at diagnosis, treatment, whether AI is between the privacy concerns, how accurate is it? So we're looking at multiple different pathways on that, but we do think that holds a lot of promise, especially for new moms who are often at home, online, but really anyone. And there's also a lot of passive, the new thing, look, basically using your smartphone, passive data collection that could look at you and predict there's a change in your cycle, whether sleep cycle, and sort of alert you that something is going on. But then the next step is going to a doctor. So, but yeah, that's an active research group.
Yeah, I will say from some of the work we've done, just anecdotally, we do certainly start to see that that's breaking through, especially with younger generations of women, that one of the only thing is to make sure you're kind of like breaking through the noise of, some of the TikTok, there's a lot of other information to compete with too, right? So these tools, we need to find the right ways to create them, but then make sure they're actually getting into the hands of people and they have a certain amount of trust. And I think that's the challenge, right? It's almost the over information and making sure the right information is getting to people. And I think that's with all the digital tools, one of the biggest challenges I think we can sometimes see is which of these is the one to trust, right? Like it's a delicate balance.
I guess the little bit of work that our group did in digital technology, it was in terms of adherence. So like, it's like, you could consider it if it's, certain apps can be considered like a medical device, right? But what happens is people seem to lose interest in them. Like, there's something they have to stay engaged. And maybe during the pregnancy, you're motivated to do so, but if you need a long-term condition, chronic condition, you see a drop off or, 6 months, I don't feel like inputting my info, or, I don't know if that's maybe a barrier, how do you keep people engaged and then have a long-term monitoring situation? Did you experience that or no?
I mean, it was I felt like it brought a lot of benefits to me initially because it gave me on-demand access to like a pediatrician, to a physician, or when I was pregnant, I was able to schedule time with like a midwife and talk through
Okay.
what this like a birthing plan with that, like, all that, where yes, I could kind of ask my OB, but typically, it's like very in and out, like with our healthcare system nowadays. So I think, but as my son grew older, and he's only 2, he's not that much older, but it definitely dropped off because I just didn't have as many pressing concerns.
Right, that's true.
But I think the platform, like Maven as a platform, isn't meant for that
Right.
monitoring aspect necessarily.
Yeah.
in what they were doing.
Yeah.
So I don't know.
Probably two different things we're thinking
Yeah.
of, yeah. So at least what we were working on was like long-term management, yeah.
Any other questions?
I guess it's kind of going back to the point around kind of raising awareness and the kind of
funding as well. Obviously, there are a lot of diseases that have been highlighted or illnesses that have been highlighted today that are kind of women's health, but there's a lot of other conditions where there's a really high disproportionate number of women affected, like Alzheimer's disease, which is obviously big news, everyone's radar at the moment. How can we leverage things like that to raise awareness for women's health? Is there ways that we can do that, through Congress or for getting extra funding? Because I know there's been lots of work to get Alzheimer's extra funding.
Yes.
And how that, I guess as well, how generally like illnesses or diseases where women are more affected, how much does that impact the kind of economy more broadly?
It's a great question. I wish I had data at my fingertips on. I don't. I know I have a lot of store up there, but that one I don't know. But I do think, what we're seeing, there certainly are certain women's organizations that have been exceptionally good at things. I kind of think I used to do a lot of work in breast cancer, and you can certainly see that there's been a lot, like if you can get a certain amount of steam behind something there, like women really, those groups pushed out and really like had a coalition. I mean, everyone recognizes and they've gotten a lot of funding. They've really moved the needle for a lot of things for breast health. What's the next, like, I feel like we need to not lose the
not being
momentum there.
siloed
There's
as
gotta
much.
be, it's hard when it's siloed, right?
Yeah.
But I do think it's finding those ways and
Yeah.
it's a battle, like where you can pick each one, right? But I think we've shown we can do it. I think it's just organizing.
Yeah, I think with regard to Alzheimer's, because women live longer, right? So you're
Yeah.
gonna, it's an age-related,
Yeah.
not everybody, but as you live longer, you're at a greater risk of developing
Yeah.
Alzheimer's. Right? So as women outlive men, I don't know, what is it, about 3 years or whatever? I think, I forget, what is the average age of death is like 81 for women. And anyway, so you're outliving the men. And so what do you do? So, I happened to work on an Alzheimer's project a few years ago, and what you asked reminds me of what we found with African Americans, where they just perceived Alzheimer's disease as a normal part of aging. And they're just like, oh, well, grandpa's forgetting where he is, because that's just what happens to old people, and it was not like this is a pathological illness related to plaques in the brain. And I wonder if the same exists with, grandma's acting, but that's expected and she's older anyway. It's not normal. It's pathologic. Do you think that might be a way to
Yeah, I
in
guess
part approach it?
because I know there's lots of stuff around the fact that women, particularly who are now older, were more likely to be your stay-at-home mums, isolated, didn't use their brains in kind of different ways a lot, and that could be linked to kind of more plaques, etc., building up. But I guess my question was more, can we bring all those kind of forces together where we know that Alzheimer's is more predominantly women, and like piggyback off that to say, look at all this other women's health issues that's happening, let's fund them kind of together rather than separately.
Right.
I don't know if anyone.
I think it's easier to fund diseases that are not specifically for women. You know what I mean?
Yeah.
I'm gonna fund Alzheimer's because, men and women get it. Just so happens that if you live
Yeah,
long enough, you have a
yeah.
greater risk as a woman, right? So I don't know. That's a tough one.
For Alzheimer's, wasn't there specifically a link to women getting it at a younger age and research finding that it was even closer to the perimenopausal age, and that, we live longer, but we live sick longer?
Oh, okay.
And the medical.
I have not seen that.
You know what I mean?
I'm not familiar with that. I didn't know that.
That was something that I recently read too, and then that made me think just about, we get a great deal of education for puberty, but we don't really, if we got the kind of education for perimenopause that we
Right.
did for puberty,
Right.
like,
Oh.
it would be terrifying.
If we
right?
could invest in that at all, it would be.
Yeah, exactly,
Yeah.
exactly.
Yeah, I mean, I think, again, it comes to, we've come so far, but there's so much farther, like, and I looked at some of these things and some stuff I didn't even show today, right, but, just thinking about how long ago they weren't even like including women in clinical trials for so many things because they thought our hormone fluctuations would mess up the data, and I'm like, but you're gonna give it to a woman.
Yeah.
Her hormone fluctuations will like, what? How do you not account for that? And it took, I mean, what, it was into like the nineties,
Yeah.
early 2000s, that they were more consistently including women in clinical studies. And it's still, when you look at some safety things in phase ones, I was looking at something the other day where it was products related to like endometriosis, and all the like phase one safety things were in men. And I was like, why?
Wow.
What on earth? How are you even going to use this? Like, how is this remotely helpful?
Mhm.
And so it's still happening. And I think the more, again, I think visibility, the more talking, the more we take issue with these things and look into it and self-advocate. I think it's important, like, read the article sometimes. Like, it's always amazing to me, we accept a lot, but we're also, we're smart. We can do a little digging on it too, and push back a little bit. Yeah.
I actually had a related question around clinical trials, because that's like one of my focus areas in particular. Like, I think, because you guys are MSL or were MSLs, I think I'd be very interested in your perspective, but I think a lot of it comes from, just educating a lot of people's HCPs, or their specialists that, particular women have, are at higher risk for, specific diseases, and to even just recognize, like, I helped run an endometriosis study, and it was really difficult to recruit.
Oh, really?
Because, especially in Hispanic and Black women, it was
Oh,
like
wow.
extremely underdiagnosed. So like, is there a lot of education that's happening in particular with, HCPs to like try to, encourage
It's
women?
very hard. It's very
Yeah.
hard to recruit, like you said, into study, into trials. People perceive painful periods as normal,
Yes, yeah.
excessive bleeding is
Mhm.
normal. You're soaking through 4 pads, a few hours, that's normal. Oh, my grandma had it, my aunt had it, I
Yeah,
have it too. It's,
and like a pain scale doesn't tell you everything, right? Like, we just
No,
had like
yeah.
a point pain scale, and
yeah, it may not be specific enough between
Yeah.
the period pain and the other non-period type.
Yeah,
But no, I, I understand what you're saying.
yeah,
Education wise, I mean, it feels like it should be some type of public health initiative.
yeah.
That's what it feels like to me, because it's too hard to do it like a one-on-one.
Yeah, it needs to be,
MSL
like,
knocking on the
widespread, yeah.
door,
Mhm.
that's just my gut feeling. I don't know what you guys, think about that, or other people, you know?
We have a huge educational initiative going, but even when I meet with private psychiatrists, say, do you have, we're talking about postpartum depression. Oh, I don't have anyone who has that. And technically, depending on there's not a lot of agreement on definitions, but when I ask a little more, even women are like, I don't actually ask. Oh, okay. And then they realize that they probably do, but they don't ask. So part of it is just complete recognition on both ends, both from the patient and the doctor,
Yeah.
and trying to be an advocate for yourself. But again, if you're not listened to or told, just power on through it. I've seen this before. Here's an SSRI. And we also have in our healthcare system, who takes ownership of the patient? Does your OB treat your mental health? Does it treat the baby?
Yeah.
So then you go back to your primary care, and after you have the baby, you will almost always go to your pediatrician for a well baby visit, but you will not necessarily go to your doctor. So can you start thinking of pediatricians, now that they're not busy enough, but where's the touch points where the moms are actually talking to their doctor? And so really a collaborative care model where, going back to the old style doctor who saw your whole family, that really caught a lot of, at the time wasn't called depression, but if you go back to it, having somebody talk to you at all the baby visits. So you're not there, you're there for your baby, but they're gonna check on you as well. That was kind of rambling. That went a little.
No, it's good. It's good.
I think it's about thinking too, how you leverage the communities, like within their own communities, because
Yeah.
I know when I was doing work in breast, for example, you also see like much higher rates among Black women.
Yeah.
And one of the big initiatives a lot of them are doing, were really leveraging their own communities, going into like the churches, going into different things to like get women to get screened and get them to trust. Again, not feeling listened to, trust, feeling they're gonna be discriminated against. They needed people that looked like them, understood them, and really were from women from within their community, to build that trust, and do that education too. So it goes beyond. We all need like allies and partners and people
Yeah.
through all of this.
There's a great company, they're called Acclimate, they're that's what they do. They're like a startup company.
Yeah.
And I work for Johnson & Johnson. We partner with them all the time to recruit for our clinical trials. And it's a digital platform and it's based around community building.
Yeah.
So they do a lot with like maternal fetal, health. And then also, recruiting. They go into the churches, they go into the communities and then that's how they build the trust, like you were saying, to get people to sign up for the clinical trials.
Yeah, actually, one of the fastest things we did to actually recruit more quickly, especially in the Hispanic population, was we staffed a call center with Spanish speaking nurses, because a lot of these women were just a lot more comfortable speaking in their native language to somebody who can speak to them about it. So, like little things like that help a
And
lot.
as you said with the screener, you don't know the word.
Yeah.
It doesn't translate
Yeah.
well. I mean, we all know too, just like phrases and
Yeah.
things that we use, so much of it is not always the medical jargon, right? Like, so how do we communicate cross languages too? I'm sure it's a mess.
Yeah, it makes me wonder also about, oh, sorry, but just quickly on this, that prevalence data, like, are there good documentations and good data sources for these subpopulations, right? Where we can go to physicians and say, like, you don't have any, but there are this many, right?
Yeah.
Like, I feel like we don't, or we would have.
Yeah, and it's hard because there's so much underdiagnosis that like the prevalence looks low, but for sure it's not.
Yeah, it's like, if we could find out what that gap were.
Yeah.
Mhm. Sorry, go ahead.
So I had a question. I mean, so we talked a lot about advocating for yourself and like the situations with your physician. And I think that's really important, but I think it also is more helpful when like the physician is like willing or primed to like listen to you. And so I think for that reason, I'm usually seeking out like women physicians, and like if I can find a Black physician, like a Black woman or a woman of color, like even better. But then one thing I'm not sure of, and I guess I had a question for you guys on this, but I don't know, I feel like they would be more willing to listen to me, like if I do have any concerns, but I don't know if there's any like data, I guess, to back that, women physicians are more willing to listen to women and like not discount their pain, all of that. Like, is that actually realistic, or is that just
There
kind of-
is some data that suggests that is true, yes. So there is, I think it was one of the one of the articles I put up there did look at that. They looked at essentially women coming into an ER with heart symptoms, and if they saw a female doctor, they were twice as likely to be, or I could be wrong with the twice, I know it was significantly higher, likely to have their heart attack recognized and be treated and live. And if they saw a male doctor, it was lower. And they just did this over many, many centers, and it was true. And they've looked at it in other ways too. And I think what's interesting is it does go both ways too, though. It's not like, let's not completely be like the male doctors are just bad. No, they just don't recognize the symptoms in the same way because it doesn't resonate with them and their personal experiences. And so what they found in some of these studies was that women do tend to be understood, feel better about their healthcare experience, and have symptoms recognized earlier by female doctors and then actually by male doctors. And I think also it's our comfort level in sharing and hearing each other in the same way. So there is some data to suggest you're not wrong to do that. There is also, though, I will also say some of that data is a bit biased by age as well, in that like when they looked at certain ERs and things that like did a better job recognizing symptoms, the ones that had more women did a better job, but they also realized that the ones that had more women tended to also be more younger doctors who were more recently out of training and more up to date potentially on what the latest is. So there's some potential skewing by that as well, and that there's benefit to seeing folks who have completed their training more recently, regardless of gender. Go ahead.
Speaking to that, it's obviously because the symptoms are different, right?
Yeah.
So what are your companies doing to ensure as they recruit for clinical trials that they are accounting for that previous bias, like that they're ensuring that they're recruiting across not only genders, but across different demographics to ensure that, like, especially if there's a prevalence in a certain demographic where previously it wasn't white men, like chronic kidney disease, that they're ensuring that they're recruiting for the right population. What are you seeing your companies doing to ensure, like, especially for women, that they're recruiting clinical trials for that?
Well, I guess I'll just speak broadly to that topic. You know, I think, and correct me, clinical trial people, you know, correct me if I'm wrong, but my understanding is that the goal was to get clinical trials completed as quick as possible, right? And sometimes you go to certain centers and you have a high rate of people coming into the trial. And then what happens is you may not have diversity, right? So then we go on the back end, where I come in as in market access or health economics, and you go to a payer and you say, okay, here's the data about my medicine, or you go globally and they say, well, you know, 1% of your trial is African-American, 5% is Asian. That's not my population in my health plan. So now how do you answer that? You know, if there's if there's differences genetically due to ethnicity, you can't really detect that in the trial. So I think companies are, correct me if I'm wrong, are motivated to create more diversity. I think it just slows down enrollment. Is that
Yeah,
accurate?
there's actually HBA guidance that's coming out now, where basically your clinical trial population has to at least accurately reflect the population with the disease. A lot of what I've been advising pharma companies to do is actually looking at physicians, because, you know, to Christie's question earlier, more diverse physicians do see a more diverse patient population. So we actually recruit specifically for those physicians to become PIs in our trials, because generally their patient population is going to be more diverse. And that's helped a lot, especially for these like really large diseases like, you know, CKD or like heart failure, right?
So you're looking more for diversity versus rather than the people that write the guidelines, kind of,
Yeah,
or the PIs.
yeah, because like the, you know, a diverse, like, you know, a black woman PI is probably gonna know more black women in their population. And that generally helps recruit more black women into trials, so. I hope that helps.
Mhm. And yeah, it is the new FDA guidance, so
Yes.
that should be, again, things that we can influence. So
Yeah.
now we do have something that is making that required. And so a positive side in that direction. All right, I think we've got lots of additional refreshments and snacks back there, not to be the pregnant girl thinking about snacks. But this has been great. Thank you guys all so much for your participation, and thank you to my panelists for your preparation and sharing your thoughts. And yeah, that's what we've got for today's presentation, and thank you. And yeah, we'll be walking around, and feel free to ask us any other questions and things too. And yes, we'll hopefully be making this recording available for all of you that registered, and we're hoping to be able to find some other forums to share it more broadly as well. So thanks, everyone.
Thanks.